Well, guys, I think we're going to get started because it is right on time. So welcome to Ivy League Learning. I'm Judy Thompson. I'm the Director of Clinical Education at AVA, and we're really happy you're here today. We have, as usual, the chairperson for this event is Dr. Kristen Jacobs, and I am happily and quickly going to turn it over to her. Kristen, take it away.
Well, thank you, Judy. Tonight we have our guest is Mike Whitner, and he works for BD as the Senior Clinical Manager in the Northeast. I think he said he's from Philadelphia. And he was previously an ED trauma nurse and an interventional radiology patient care coordinator and the lead vascular access specialist. And he is at home presenting to us with his two small sons, Colton 3, Seth 9 months. And he's got them upstairs locked into a bedroom, I think. So Mike, we will turn it over to you and for tonight.
Great. Yeah, thanks for having me. Very excited to be here. Again, I'm going to try and make this as interactive as possible. So if people want to chime in with questions in the chat, just interrupt me. I will stop a few times just to hear everybody weigh in on their thoughts. So let me share my screen here. We are going to talk about advancing the frontier. Now, everybody may say, well, we already know that we need vascular access teams, that we want to look at a comprehensive approach, right, to our patients. Specifically, though, we want to try and see everybody's thoughts here and gauge what is happening out there in the country surrounding everything from blood draws through CVAD insertions. So what do we mean by that, and where are we going to start? So we started this kind of venture and story a few months ago when we realized that obviously blood draws are happening in numerous patients. We all know that. IVs are inserted in countless patients, sometimes successfully, sometimes not. And we have numerous challenges that we have in healthcare. We've had them forever, but they've only pretty much gotten worse. So when we're looking at the challenges in healthcare, we know there's challenges with technology. Technology is great, as we just saw, doesn't work all the time. We have the ever and always patient safety and quality challenges, staffing shortages, along with burnout. And we always have those high costs, especially in the US, with supplies and staff, operating costs, and our friends Medicare with the way in which hospitals are reimbursed. And of course, we always have to throw in patient satisfaction. These challenges were actually from CEOs. These were the top challenges. What I found most interesting, though, in these challenges was that CEOs highlighted most often that nursing shortages were the most pressing workforce challenge, and they were actually quoted saying it's what keeps them up at night. So we have the highest of the high people, right, at these institutions noticing that there is a nursing shortage, number one, and that it's the thing that they don't really know how to solve for. So how can we solve for these nursing shortages paired with only ever improving patient care? When we were out in the field and around the country, these challenges should be no surprise. They're running rampant everywhere we go. There are always these multiple tasks that are being added to burdened healthcare workers. There's ever increasing turnover rates for RNs and phlebotomists, as well as other healthcare clinicians. I think one of the latest stats I saw was 22.5% is the average turnover rate. Does anybody know or are experiencing these rates of high turnover at their institutions?
Most definitely, yes.
Yeah. And we're obviously all seeing that there's a shift in level of experience. It was definitely something that was occurring, that we had a lower level of experience than in the past. However, that has definitely been expedited with COVID. We have low level of experience in critical care areas and also joining some specialized teams. When we have that low level of experience paired with our difficult venous access patients, which we all know have not left the healthcare system, they've probably only increased. it really exponentially increases the rate of all the different complications that can occur with our vascular access patient population. Again, on here, I don't know when we can get rid of it, but we always have that increased rate of CLABSI. Definitely noticing, and literature does show that CLABSI rates are much higher post-COVID than pre.
I was
haven't-
just saying ours are back to normal.
Yeah.
Love to hear that. That's great news. A few of the institutions said that theirs was actually 300% higher than it was in the pre-COVID, and they're still up. So love to hear that they're trending down for some of you. And then one of the biggest challenges or thoughts out there is now we're all talking about HOB. We know that it's coming, it's been approved, but how is it truly going to affect healthcare? How is it going to affect the way that specifically vascular access experts can become even more influential than we all already are in serving our patients? And when hospitals are penalized for peripheral IV infections along with CLABSI, what is that truly going to do to the outlook and the ability to justify increased resources for vascular access? Because of these challenges, there are a few solutions that we've noticed that have been kind of thrown out there to see if we can solve for. One of the potential solutions that we see is moving towards decentralized care, meaning we have specialized teams that are being disbanded. However, on the flip side, we also see institutions that are innovative. Nursing care models are changing. They're implementing team nursing. LPNs and unlicensed professionals scopes are expanding in order to provide more specialized care. It started because there just were no RNs or clinicians to perform those types of procedures. However, it's beginning to become more normal in certain institutions. And what we're finding in observations is that these small groups of unlicensed professionals or of LPNs that are having added tasks are actually doing these procedures better than the registered nurses, because they can have that time and focus and they're not being as overburdened with multiple tasks. Does anybody see those changes in their facilities surrounding additions of LPNs or expanded scopes of unlicensed professionals?
This is the first I've heard about it.
Okay,
Yeah.
great.
I've seen a lot of LPNs.
Okay.
Yeah.
This
And-
kind of reminds me of back when I first got in nursing, back in the early '80s.
Yeah, it's funny you say that because two of the CNOs I spoke with, they said, you know what I did? I brought back the ideas we had in the '80s. And I said, you know, history does seem to repeat itself, doesn't it? So that definitely resonates, because we are seeing care models come back that were out of vogue per se, because there were so many, or there were not so many, but enough RNs, but now there's just not. So it's either we have people to care for patients or we don't have anyone. So touching on these decentralized care models, this is something that hospitals consider moving towards, and an example of that would be dissolving phlebotomy services specifically, and then giving that task of blood draw to floor staff. The reason that hospitals seem to do this is because they feel that it's going to decrease cost because there's less heads, less people doing this work. The turnover rate goes away right away because there's no team, so there's nobody to turn over. And it is kind of a stab in the dark at changing their current care model because they realize it's just not sustainable. All these things they feel are solutions. However, it does seem to only perpetuate the problem that we're all kind of experiencing, because we're just offsetting this work to clinicians that are already overburdened. Has anybody seen this shift at all, specifically with phlebotomy services being disbanded, or any other teams?
At my place, the the IV team or patient support team, what it used to be called, as well as now that has always been mostly LPNs, and they've been doing blood draws on the floor for years.
That's interesting. So, oh, sorry, what facility or what hospital are you from?
I work at Portland, Oregon VA.
Okay, great. And the LPNs, are they on every floor there doing those draws?
This is just on the vascular access team or IV team, but there's no LPN that actually works on the floors. They're all in the
Wow.
clinic.
So they would do the blood draws that were escalated to the team.
Right.
Got it. Got it. Okay.
I work at a pediatric hospital, Nationwide Children's of Columbus, and we haven't had phlebotomy teams since I've worked there in 2006. Pediatric centers went to a lot of capillary draws, and at that point, phlebotomy teams were pretty much disbanded. But we continue, I lead the team, and we perform around 1,000 lab draws a month. So we have essentially become that phlebotomy team, it feels like.
Yeah. And when you perform those draws, do you use a butterfly or a push button and ultrasound, or no ultrasound, or a combination?
Looking at our data so for our IV placements, we use ultrasound about 70% of the time. For our lab draws, we're using it closer to 25-30% of the time. And because we are a primary insertion service, we're used to angios, so we draw almost everything with an angio catheter, even if it's strictly for labs. We'll put the angio catheter in, draw the labs, and then remove it.
Got it. Yeah, we definitely see that. Clinicians, myself included, when I was bedside, gravitate towards what we're most comfortable, because we feel like we're going to be able to get that for the patient as quick as possible. So that's definitely something that we see. But yeah, so phlebotomy services specifically is just one example, right, of a service that could be disbanded, and then those tasks given to other nurses or unlicensed professionals or LPNs. However, when we do this specifically with blood collection, it's been shown time and time again that what happens are increase in workforce challenges. There's potential to delay care and also delay discharge decisions. Some of these stats are pretty staggering for me anyway, when I saw these. So when we have these blood collection models that are decentralized and not specialized teams, there was shown to be an 800% increase in hemolysis. Does anybody know what the cost of one hemolyzed sample is before our current day inflation? Any stab at it?
300?
So it's $208 before inflation in the inpatient setting, with all the different delays and things that can occur. So if you have an 800% increase in your rate of hemolysis, that's some substantial money that is being lost very immediately. So you can kind of see and start to see how this decentralized mentality of removing specialists or those teams dedicated to these things can quickly increase cost versus decrease cost just by cutting the actual FTE. Some of the other things on here, RNs collected 85% of rejected samples. So think about that. The RN is collecting way over the majority of those samples that are costing the institution a lot of money, with delays in care. And also, if you have a rejected sample, you have to redraw it. When you redraw it, the median lag time for that is 65 minutes from the time that the test result is available to actually having a physician or provider being able to inform care. So you have over an hour delay right there. When we add these additional tasks, we also add an hour of additional work in the morning, specifically to the bedside clinicians that are already overworked at that time. Patients are waking up. We all know patients are needy at that time of day that blood draws occur. And when we add increased workload, it only leads to the clinicians rushing to obtain the draws, and also clinicians not being able to either get to the draws or prioritizing other things over those blood draws. When we have these delays, in the blood draw and the clinical read time, that's CRT, is delayed, those abnormal results that aren't actually resulted increase likelihood of prolonged length of stay by 33%. So you can see how all of these things can lead to very frustrated physicians who can't make informed decisions, overwhelmed RNs who are being burdened by increased work, and ultimately dissatisfied patients. When we look at the CDC and INS, they do have professional body statements on the promotion of specialized teams. We know that INS and CDC also give us some reasons and ways that specialized teams are effective. They help to reduce infection, complication, and cost. So just going to keep this slide up here for a few seconds. These are just examples of different specialized teams. Obviously on the left, we have those that are non-vascular access centric. In the middle, we have teams that are vascular access peripherally, meaning these are teams that may have been created to do other procedures. However, they have had additional tasks added to them to care for patients that need maybe difficult venous access. And then on the far right, we have those that are vascular access centric. We have phlebotomy teams, PIV teams, PICC midline teams, and then what we would call our vascular access team. We're going to come back to this slide in a second, but I want to show and kind of start to build some of the burden that happens when we have the inability to obtain blood samples and obtain IV access. So 60 to 70% of decisions are informed by actually collecting the blood and resulting specimen. Obviously, this is very frequent. We have up to 90% of patients hospitalized getting an IV catheter. So these are some high percentages of patients, right? So if we can show and can actually impact this portion of patient care, it's going to drastically decrease a lot of cost and increase a lot of satisfaction, which is where we're going to get to. So we know probably that complications obviously arise from these procedures. Blood draws, 33% are difficult sticks. We also know that's true for IV access. When we're placing IVs, we have failure rates until intended therapy is complete of up to 50%. All of these things lead to a trickle-down effect of clinical inefficiencies. We have high complication rates, high failure leading to multiple IV starts. We have poor sample quality, leading to, again, multiple sticks, redraws, delays, inappropriate treatment. All of these leading to venous depletion, compromising for future care. That's what we're all here for, vessel preservation, right? At the end of the day, they all lead and point toward clinical inefficiencies, patient dissatisfaction, and of course, impact that all-important bottom line of the hospital. So I want to go back to this slide and just say, what if we can promote, and there are facilities that are beginning to do this, a comprehensive vascular access team that has phlebotomists, unlicensed professionals, LPNs, RNs, nurse practitioners, all on the same team, under the same roof, and justify and show how that team can make standard of care decisions across the board to decrease inefficiencies, to improve patient satisfaction, to improve clinician satisfaction. Could we all get on that same page? Do we feel that's a good idea or is it a bad idea? Bad idea? Okay, well.
Great idea.
So if we can do that, what could we have the potential to do? We could have the potential to impact the patient, the clinician, and the hospital. All of these things on this slide are from the literature. We know that these things are ways that a vascular access team can impact our patients. But imagine if we could combine all of those different procedures from blood draw to CVAD insertion and show how to justify and put everything together to decrease CLABSI up to 90%, to improve those clinical outcomes and patient satisfaction, to continue to improve our first stick success and our clinician satisfaction, which is definitely something that is almost, if not just as important as patient satisfaction nowadays. CNOs, hospital administrators really want to understand how to satisfy clinicians. And one way that has been shown for that to happen is by having those vascular access teams available so they can feel that that expert is there to provide what they know is the best thing for their patient. And at the end of the day, the hospital is going to see unnecessary length of stay reduced. They're going to see an increase in clinical efficiencies, and they're going to see an overall decrease in healthcare expenditures. So the larger volume of patients that we can impact, being that peripheral IVs are inserted in up to 90%, blood draws occur at a very high rate. I've seen some above 80% of patients get a blood draw in their hospital stay. If we can impact those two things and make them more successful and more efficient, then we're going to really show the value quickly of a comprehensive vascular access team that provides every service to each patient. So this is where we're going to get more interactive. So a lot of these what ifs, you may say, yeah, we can do that. We definitely have that under our belt. But what if we could give bedside clinicians time back in their day? Obviously, we know that's a good thing. But what could they do with that time? They could care for their patients. I've had family members recently in the hospital, and I have definitely seen a decrease in just necessities of patient care, decrease bed baths or just baths, toileting, all the things that take forever but make people feel human again in the hospital. That's something we could give back to the clinician to impact our patient when we have these specialized teams. What if we could improve patient care relating to vascular access, specifically those common procedures, blood draw and peripheral IV? So I want to stop there and ask the group for a little interaction here. But how many of your teams insert peripheral IVs? Do we have anybody on the call that you are part of a peripheral IV team? Your team is the only team that inserts peripheral IVs in your institution.
Oh, sorry, I gave you a thumbs up and I'm going to retract it.
Okay. All right, so nobody inserts all IVs. I would assume we have people on the call, obviously, that insert IVs on their team, so I'm not going to go there. But how many do blood draws? Do we have anybody that does blood draws?
Yeah.
Yes. Oops. Okay. So when you do those blood draws, do you have anybody on the team that specializes in doing the blood draws specifically, or is it just as the orders come through?
As the orders come through.
And I would assume the hard draws are escalated to your team?
If it has to be drawn through a central line, we have to use a kit.
Okay. So only the central line blood draws are escalated to your team.
And if they're ordered to be drawn, because our policy,
So you also have the policies that state that you can't draw blood from a central line unless a physician order, I assume?
correct.
Got it. So that's a CLABSI reduction strategy, probably?
Yes.
Gotcha. Are there any other CLABSI reduction strategies surrounding blood draws other than just not using central lines that you know of?
No.
So I'm going to skip one, but what if the specialized clinicians could improve vessel preservation by utilizing devices and processes to solve for current healthcare challenges? What that means is if we could improve vessel preservation, but also take it a step further and not increase risk for infection, would we agree that that's probably something that would benefit our patients? Yeah. So one way that we can do that is by utilizing blood draw devices that are, needle free, that help to reduce needle sticks. Does anybody use any devices that would do that other than just drawing from central lines with syringes?
We use vacutainers on central lines, or I personally do. I mean, and we allow all our nurses to draw from central lines. Yeah.
Okay. So
Pediatric center here, we routinely draw off of our indwell peripheral IVs. I mean, that is our first line method, sometimes with a syringe, sometimes truly just gravity, removing a needleless connector and using gravity to, the not probably best practices that most would tell you, but dripping into the vacutainers when you pop the lids off.
yeah. So if there are solutions, like Pivo or something that could promote the ability to not stick our patients, but preserve our vessels, it sounds like that could be a benefit. Maybe we could also kind of lead to the idea that if we had dedicated teams that would do our blood draws, especially in our difficult access patients, to minimize accesses to our central lines, as well as decreasing, issues with accessing peripheral IVs, like some that were just stated, could definitely be beneficial. So I think one thing that I want to really hear from the group is, what does comprehensive actually mean when we're talking about a vascular access team? What is that definition? Does that mean that this is a team that does the difficult access in the hospital? Or does that mean that this is a team that truly does everything related to vascular access? And how do we start those conversations surrounding having a more standardized approach to a comprehensive vascular access team? Any thoughts there?
I have a couple of thoughts on that. We always joke on our team that the more IVs we do for a lot of these floors, the less the nurses are developing their skills. And there's a balance to be had between always calling the IV team and then never having an opportunity to improve your own IV skills. So I think there are plenty of patients that are that have veins that could be gotten without ultrasound, because we'll go to the room and not even use the ultrasound. But the nurses they're losing skills, or they're not even developing. The newer nurses aren't even developing insertion or venipuncture skills. So I don't know that I'm on board with having a team that does absolutely everything, because now we've taken away that learning from the nurses on the floor.
Sure, and I definitely hear you there. I think there are two food for thought kind of things, or two categories of thought. And I do agree with you that we don't want to take away that skill. I don't have the right answer, obviously. I'm just having conversation. But when we have the level of experience we do, at what point is it going to take decades, you know what I mean, to get back to a place where we have bedside clinicians that are afforded the opportunity to even gain that education? I hate to say it, but even I just had a call today. I was at a facility, and they said that the IV education was removed from their nursing orientation. So they're not even giving them the opportunity to be educated. And then all of a sudden they're on the floors and they're expected to just miraculously be able to do this skill. So I do hear you, and I do agree with you. I'm just curious if there's any thoughts on the nuances there, the differences there, or any perspectives.
I just want to say I work at a major medical center, and we're not overly huge. I mean, we've got probably 700 beds, but it was estimated at one time that approximately 80,000 peripheral IVs are placed a year successfully. That doesn't include all the failed attempts. But our team, besides placing PICs and doing complication management, I think on average we place only 8,000, although I think this year it's probably closer to 9,000 ultrasound guided IVs. So we are only going to get the orders on quote unquote the diva patients. We do not have it's going to come down to a matter of the budget to be able to really provide more comprehensive. That I think there are better ways to use our and we are expanding, but to use our expertise. So for example, is we are one of the hospitals that's not moved to clinically indicated removal because we're not seeing good practice to begin with. And you can't move to that unless there's a good foundation of placing them appropriately, assessing them appropriately, removing them appropriately. And there are people who just want to move directly to clinically indicated removal because of the Cochrane review, blah, blah, blah. But right now, they're ignoring the risk of HOBs from peripheral IVs. And our influence, I think, could be broader in supporting surveillance, auditing, and improving care as a support. So we're the backup for difficult IVs, and we are expanding to difficult blood cultures. The problem is our schedules are completely full, and when they order an ultrasound guided blood culture, the timing is critical. So they can't wait hours. So I hear what you're saying, that specialized teams that take over all of vascular access could reduce complications, but you have to balance that with how expensive they are and what the total hospital budget, where are they going to find those sheer numbers of people, let alone that skill level. So I just want to throw that out.
No, thank you for that. I totally agree. And that's one thing that when we went down this journey and looked at these things, that was kind of paramount, right? We're in a time when there's high rates of turnover, when hospital can't even fill the positions that are posted, right? And we don't want everyone to lose those skills. Agree with everything said there. I do think that a few things you said, I think what we want to promote here are consulting type of positions for the vascular access RNs, where we can have them in those exact positions to audit, to show our expertise, to really show how to perform and improve that performance of products, of process, and be at the table to lay in on what policies should be most appropriate for your institution. So that would be the RN's role. And then part of this comprehensive team may be adding additional unlicensed professionals to do things like the blood draws. We also have multiple examples, and I have to say, until I saw it for myself, of LPNs and medical assistants that do wonderfully with insertion of peripheral IVs, medical assistants specifically, as well as obtaining blood draws in appropriate order of draw and having that focus. So I think there may be a place where we can get to where we have multiple disciplines on the same team to, again, offset cost, but also to show that having this approach will ultimately improve patient care while being economical. So those are kind of just some of the thoughts. But no, thank you. That was a very succinct question and comment.
Michael,
Yes,
can you hear me okay?
I can.
Okay. So I've worked for level 1, 2, and 3 hospitals, small and large, and over the course of the years since 1990, where I see it, and this is nothing new. I mean, I'm sort of surprised in one way of it comes across to at certain facilities that this is a brand new factor of nurses not knowing how to do an IV. And in fact, if you go to the universities or whoever's doing the nurses training, they haven't been doing it for 20 years of teaching, and if not more, of IVs. It's the rare exception that you find a program that is actually doing any of that teaching. They expect that the hospital will do that, and it's vice versa. And so it is almost impractical to have a hospital try to teach every nurse to try to do an IV. It just doesn't come about. I don't care the size of the hospital, whether it's small or large. And unless the education is going to be totally revamped and gone back in time to where that becomes more of a standard before hire, or if the hospital is saying, okay, we'll take this education on, but here you've got your numbers proving that if you have a team and your group, and then you're proving that they have the expertise, it seems I don't know. I mean, the dollars just show right there the support for the team versus the other way. And yet, administration, I've been at multiple hospitals that they go, "Well, we're just going to keep shrinking the vascular team down," which it just doesn't make sense.
I'd like to make a comment about that because when I've talked to very high level, and not that I've talked to a lot, but a few very high level nursing school administrators, the way nursing education has moved is much more to teaching critical thinking skills. Because the future, I've been a nurse for 43 years, and what I was taught in nursing school, and yet what I've done over my career, really is to be able to advance in terms of the scope of my practice, is really developing critical thinking skills to embrace new concepts, new paradigms, and new technology. And so the future of nursing, and the future of medicine, you can't always absolutely have a crystal ball to know what that's going to look like. But what you can teach people in nursing, medical programs, et cetera, is how to think critically as new information and new technologies come along. So as specialty teams, we embrace high technology and critical thinking to provide the best level of skill. But that huge gap that you're talking about is very real, because it's purposely done that way, because they can't just keep teaching skills in nursing programs when people may or may not use them in clinical practice. And in a few years, it may be outdated. So just to sort of be the advocate, and I am not a nursing school instructor, but just to be an advocate for what I've heard, and then what hospitals face is we make the assumption that everybody has the same background information about, for example, starting IVs and assessing central lines. And the fact of the matter is that's not the case. Just want to put that out there.
Thanks, Nadine. I think we have
Yeah, I think some of the last things discussed were really what we were observing, those big gaps, and we're understanding that the focus and the hyper focus, for good reason, picks midlines, difficult access patients utilizing ultrasound. But it may be time to take a step back and see how we can incorporate these things that are what we would consider maybe low-hanging fruit, but honestly have a huge impact on the majority of patients in our institutions. One of the things, I don't know who said it, but pertaining to education, is just so true, that there's that gap. Critical thinking, yes, we do promote that in nursing schools, but then the flip side of that is we could have an PIV insertion courses and nursing orientation, but then when those nurses get to the floors, they don't have, typically what I'm seeing anyway, that ability to have that sustained education and really good critical thinking surrounding, not critical thinking, just experience of how to do these common procedures appropriately and expertly. And so when we don't have those people on the floor anymore, it's only becoming increasingly more difficult, which is then causing expansive delays. We're talking thousands and thousands of hours of patient delay because of these blood draws that aren't able to occur until they're escalated to that specialized team. So if we had the ability to decrease those thousands of hours of escalation that are occurring by getting blood draws quickly, we feel that there may be a huge opportunity there to really justify why there needs to be a team, to preserve vasculature, and ultimately to decrease that overall hospital strategy of the length of stay of the patient. So that's kind of where we ended up, where we came to. Does anybody else want to add anything there?
I do believe that comprehensive vascular access is achievable. I think it's going to take a strong business plan. I know Lee Steer's done a really good job of it, and there are models out there that show that by throwing money at as a resource, that you can save money on the back end. But it takes a really forward thinking administrative team to be able to see that. And I think, hats off to Lee. He's done an amazing job to get where he's at with this. But I think that's a model that we really do need to look at. And Mike, I love your idea about using some other complementary services to help us to lower the cost. And I know in Arizona, there's a whole lot of folks that use respiratory therapists. I think that's phenomenal. Phenomenal. I mean, let's think outside the box and do better for our patients, because what we're doing right now is abysmal. If we know that it takes 2.18 to 2.5 average attempts to get an IV in, that's ridiculous, honestly, in this day and age where we have technology that can get us at one go. If we know that a third of the time we're going to have a complication on a device, as on average, 1 out of 3, that's ridiculous as well. So I think there's my soapbox.
Yeah, no, I mean, totally agree. And
Yeah.
Oh, go ahead.
I was just going to say, Judy, I am with you. I have that debate with my leadership team and my CNO often. My CNO is very driven. We need to maintain the scope of practice of nursing, and I'm like, but they're not doing it. They don't come in with the skill set. And if we can do better, save money, reduce complications, increase patient safety, then why are we investing this effort into it? Yeah, and I think we have to look differently on how if we go that model. You're right, you're not going to have nurses come in with any vascular experience. They're not going to know how to place an IV. They're not going to take the thing out of the package. So we have to have the ability to onboard them from that point. They don't start out placing PICCs. They don't start out, with those really advanced critical thinking procedures. They literally learn how to start placing IVs in the easiest patients. And slowly, through a clinical ladder, which helps with retention, they can move to those more advanced procedures. Is my passion and desire. I don't know that I'll ever get there, but
Me either. But we have to try. We have to try.
Yeah.
We're not doing right by people.
Yeah, and that clinical ladder is something also that has been discussed with the multidisciplinary vascular access team and thoughts, right? Because you then have built-in med techs, patient care techs, or LPNs that are the vascular access expert to the top of their quote scope. And then they already have that passion to continue to grow. Maybe go back to nursing school. Now I can do everything, PICCs, you know what I mean? You kind of grow that future of vascular access. And personally, that's what I feel is going to be able to sustain and grow this entire, expert group that we have.
Yeah, and we did that, pandemic when we were really hit hard at my team of no staff. I just needed more people not to quit, so I hired a PCA. I mean, the person didn't have a skill set to really help us, but they could go get us equipment and they could help hold for the patient. And I didn't have to go locate a nurse on a unit that was short staffed. And she recently was, just advanced and took her RN, so it is possible to do. And I agree that's a potential model.
From our lips, we got to make it happen somehow, guys.
Can I throw out one idea to the group too? Our team has talked for a couple of years about hiring a paramedic, and because they have the ability to place IVs, and we could train them up to our standard. And they would primarily do blood draws on difficult patients, but they could also assess the existing IV, and if it needs to come out, which they frequently do, and then place a new one at that time. But primarily the job would be for blood draws. So I think they were probably more expensive than a PCA, probably right on par with what an LPN would make.
Yeah, Cindy, we went that route too. And I have a paramedic on the team as well. The state of Ohio limits paramedic scope of practice with a specific statement that says they cannot provide care to patients outside the emergency department. So I had the qualifications paramedic, but that's not their role. They're actually considered an unlicensed individual and are doing those very, very same things. So there's definitely still limitations, but the challenge going into my hospital leadership and my scope of practice committee, I'm a medic myself as well, was a medic first, went to nursing school. It was, well, why do you want a medic to do it when a nurse with a bachelor's degree is there? And I'm like, because they don't know how to do it. I came out of medical school and it started 200 some IVs in a year-long program. Nursing, I did one on a simulator that I had to do. The rest I chose to do.
Well,
And
that's
that
good
right there,
information to know. I knew that there was some kind of licensure thing there, but I thought maybe the hospital could, since they can work in the ER, I wondered if maybe the hospital could just say, okay, well, we're going to hire you as an assistant and not call you a paramedic.
And that's what we did. We had to go
Okay.
down that route, and they're considered an unlicensed assistive personnel. But then you take away that experience of critical thinking and assessment that they do have. So like my person cannot assess a bad IV. They can put it in, they can draw blood off of it, they can do all those things, but they can't say that this IV is bad because as an unlicensed individual, you can't assess.
yeah, and I think
Well,
one
where
thing,
some places have done is that they've, like you guys have said, they've used the qualification that maybe they had the paramedic training in the background. But like I work ER and I've done ICU and flight. There's things that I have had to do, but my training was done by the medical director. So like when I flew, I went beyond the regular standard nursing scope of practice to do different things. And that's what a lot of EDs have done, is that they have used their doctors as their medical control and saying, okay, we're having you draw blood and do extra training and teaching. And then they're able to utilize that route, but not within the hospital. Because most, you're going to have a hospital-based medical director to qualify them.
Guys, this has been an amazing conversation. And Mike, thank you so much for your presentation today. This was wonderful. Great conversation, great presentation today. Thanks, everybody.
thanks.
Thank
Thanks
you.
for having me. Have a good night.
Bye, everybody.